Until the pandemic came and hit us, I think a lot of people were not quite so aware as to how much our lives are impacted by global events that might start anywhere.
This is a real crisis.
I mean, it's been clear that this was likely to spread in the US.
We need to be thinking much more ambitiously.
Climate finance is a very big issue.
We, the Center for Global Development, we're a group that try and see how we can make the international system that supports global development work more effectively.
CGD came about because it was time to focus not only on what developing countries should do, but much more on what the rich world should do.
How do we finance infrastructure in the poorest parts of the world? How do we increase productivity in agriculture? What kind of policy brings out the best outcomes?
Some of our previous work has helped to come up with a kind of innovative financing mechanism that was used to help launch pneumococcal vaccines. We really have researchers and experts here at CGD who come at these issues from multiple vantage points, and I think that's just what helps make our research more rigorous, more rich, and actually more connected to the realities that decision makers are grappling with.
We've been looking to CGD for all of your research and analysis to guide us.
So CGD is nonpartisan. Because of that, over the years, that credibility has given us significant convening power.
Our government highly values the work.
What CGD is about is you can ask those difficult questions that people refuse to ask and actually find solutions.
We're thinking about how climate change will impact migration patterns, how that will in turn have impacts on people's health.
It's challenging to be able to align budget with ambitious programmatic goals, but it can be done.
Every single time that we're able to get it right, it means we're reducing significant poverty.
If you can help to make things a little bit better, that's a good way to spend your time.
Welcome everyone to the CGD event, Beyond Revising Entitlements, the Implementation of Health Benefit Package Revisions. My name is Pete Baker. I'm a Policy Fellow and Assistant Director of the Health Programme here at CGD. And today I'm excited to be moderating this important event, which is come at a very opportune time. As we look forward to 2023, we will see a lot of challenges on the road to UHC. Many countries are struggling financially with the economic crisis that's come after COVID, and are struggling with the debt crisis and increased interest payments. It's estimated that around 38 countries now will have lower government revenue in 2027 compared to pre-pandemic levels. And this means if we are all to stay on the path to UHC, we're going to need to focus, we're going to need to prioritize, we're going to need to make difficult choices between what's provided and what's not. Explicit health benefit packages are a very unique tool in that endeavor. They help represent a kind of commitment between governments and the population about what will be provided, what services will be provided, and to who, and at what cost. But the challenge, I think, here with health benefit packages is not just defining those services, but keeping it up to date, maintaining it and revising it regularly, but also matching it to make sure it's implemented, matching it to budgets and matching it to implementation capacity. And that's really the focus of this session today. We're taking a look based on a recent release of an important guide from the Joint Learning Network of the experience of 14 countries in revising the health benefit packages and experiences they had and how they revised it and the lessons they learned. We'll start off with an introduction from Srobana on the key issues that we're talking about here today. And then we've got an excellent panel of 4 that I'll introduce individually to save time. And then at the end of that, we'll have Q&A. So please submit your questions. They can be submitted via the YouTube link or via email or via Twitter. And these details will be provided on screen. So without taking any more time, I'm excited to introduce Srobana Ghosh, who's a CGD policy analyst, who will take us through the introduction before we start with the panel. Thanks, Srobana, over to you.
Great, thank you, Pete. So I will be discussing a little bit about why HBPs need to be updated and elaborate on potential reasons for revisions. And I'll be broadly discussing some of the challenges in conducting revisions based on the advice in the guide that Pete mentioned. And I just want to mention that we also have Rob Balthusen today from Radboud, who will also be helping to answer questions later. So can I just bring up the slides, please? Lovely. And then if we can go straight into the next slide. So to begin with, I think we need to state that all countries exist in a continual state of flux. Conditions are never static, and therefore revisions are ultimately essential to ensure that the health benefits package updates to stay aligned with the country's objectives. So what can change? On the right, you'll see some of the main reasons for revising a health benefits package. So first we have changing disease burden. Many LMICs are familiar with the fact that they face changing disease burdens. NCDs are rising, and an HBP that doesn't account for this can leave people unprotected against financial catastrophe and mean it limits their options for services. At the same time, there are more and more health technologies becoming available, particularly for NCDs, meaning that there is a higher demand for some of the most expensive treatments. Also, new interventions can make previous interventions outdated, and if they're no longer best practice or cost effective, then they should be removed from the benefits package to make way for the most cost-effective or impactful treatments. This increase in demand for health services creates a need for cost-effective treatments so that the overall cost of the health benefits package can be balanced against the available budgets, which is also affected by other external pressures. And then there are fluctuating priorities. COVID was a very strong example of how country priorities could potentially change overnight, but other priorities might exist, such as the need to protect vulnerable groups, and that could influence decisions over the services that are covered. So revisions are necessary to also address problems that are found during implementation, particularly if the HBP is found to be aspirational, which has been found to be a fairly common problem by most countries. The Joint Learning Network survey found that countries stated that their main reason for wanting to revise their packages was due to insufficient financial resources for delivery. So revisions can help address these changes, especially if countries move towards a more explicit HBP, and this can help decide entitlements. However, whilst they're important, revisions can be difficult if they're not done regularly. Next slide, please. So we found in our research that revisions tend to be rare because they are so challenging. So insight from the Joint Learning Network found that quite a lot of countries had not, in fact, revised their benefits packages. One of them hadn't revised in 27 years, another hadn't revised in 19. Periodic revisions mandated by law do help ensure that the benefits package is updated regularly. And there are a few countries that conduct this, suggesting that it is achievable, but it isn't common practice yet. So in our research, we found that the reason why multiple countries had not revised their HBP was because of the limited capacity in the system to conduct revisions. This is because making the challenges to making revisions are both complex and contentious from a technical and political perspective. On the technical side, it can be challenging if a country does not have the resources, capacity and data to know where an HBP is failing and how it can be improved. Without this information, the revision is in danger of repeating the original problems of the first HBP. Therefore, it is necessary to have a meaningful, deliberative process to make sure that the revision can be structured in the most impactful way. But even if the revision was made with perfect information and process, without sufficient political economy, the revision can fail if stakeholders will not implement the decisions or if there hasn't been enough coordination with the Ministry of Finance to ensure that the package is in line with the available budget. The implementation challenges of revisions are therefore very serious as they're so complex. And because of this, JLN research has found that revisions can take a very long time. For example, one country took 4 years to conduct their revision. However, rushing the process can lead to other problems. Another country tried to expedite the process and took 1 month to conduct their revision, but it ultimately failed due to a lack of stakeholder engagement. It is therefore so important to overcome these challenges because the opportunities that revisions provide to help further the goal towards delivering UHC, but countries have found that there's very little guidance available to tell them how to do so. Next slide, please. So we found with the JLN research that many countries found revising their benefits package challenging and there wasn't very much guidance available. And so the subject of revisions was selected as the topic of the latest Joint Learning Network knowledge product launched this week. So together, the Joint Learning Network Efficiency Collaborative, with facilitators from Radboud, UMC, and the Centre for Global Development as part of IDSI and the World Bank, have produced this guidance, which shares practical lessons on updating HBPs based on the experiences of 18 countries. Has been developed by countries and for countries, and it includes guidance on all the topics that you see on the right. Next slide, please. So, to conclude, revisions are difficult, but they offer immense value. But for them to do so, revisions need to be done systematically, be well resourced, have good governance, stakeholder engagement, and be part of an institutionalized process. Here, the JLN HBP Revision Guide offers 5 principles that can help make the revision process stronger. We say that HBPs are an evolutionary process. As time goes by, revisions can help the HBP to mature. It's important to aim for universal coverage of existing priority services before expanding the package. Because when resources are scarce, it is essential to cover the most important services, such as maternal health, before moving on to more complex treatments. Revisions aren't just about expanding packages. It's also important to disinvest in low-value services to help target resources better. You should ensure that revisions to the package are costed within budget and appropriately resourced. And finally, institutionalizing periodic revisions will keep the package updated and help stay on the path to UHC. I now wish to turn to the panel to discuss their experience with these themes a little bit further. Thank you.
Coverage of some of the key issues here today. I liked how we talked about the kind of technical and political issues at play in health benefit package design. I now turn to Jacque Mallender, who's Director of Economics by Design, who will be discussing some of the experience in Sudan, hopefully with Mohammed Musa, who was from the WHO office there, who was joining her, if we can make the technology work. Thanks.
Yes. Thanks, Pete. Could you possibly pull the slides up, please? Whoever's in charge of slides. Thank you very much. That's great. So hello, everybody. Mohammed Musa and I are delighted to have been asked to give a short presentation of the work being undertaken in Sudan on their priority benefits package development, in particular, the planned institutionalization of that. Next slide, please. Just a little bit of background to kick us off. It's a very large and diverse country. There are 18 states. And each state is, very different. And for the last decade, Sudan has been significantly impacted by conflict, and it's still in a transition to civilian rule. So there's still some very big contextual issues. Next slide, please. In terms of the health needs of the population, they really do reflect the poverty and conflict which has been experienced, and there's significant health need from communicable disease and health problems associated with poverty and economic hardship. Next slide, please. So in terms of health services reform, despite all of these challenges, the government is really strongly committed to universal health coverage and has embarked on a big programme of reform. And it's really important, I suppose, from my talk to contextualise the priority benefits package within that wider health service reform. So we're going to focus on the priority benefit package and the institutionalization, but it is in that context. Next slide, please. And there were a lot of wider health system reform objectives within which that priority benefits package is being implemented. Essentially, I'm not going to read them all out, but they are fundamentally about reducing health inequalities, improving financial protection for citizens, improving quality and outcomes of services, improving efficiency of the system, and also really fundamentally improving health system governance. Next slide, please. Just in summary, the reforms envisage a model which is financed from a mix of government funds and insurance premiums, with a clear separation of the roles of the payer and the providers for health services, and with the appropriate sort of governance and regulation around that. And all of that nested within a government-sponsored multi-sectoral programme of health in all policies and ill health prevention. So the priority benefits package sits within that relationship between the payer and the provider. Next slide, please. And we developed the package using a very systematic approach, which was adapted from the draft guidance available at the time from the WHO EMRO. I'm not going to go through the process in detail, but just to say that it really was about having a very systematic look at each of the programs, the candidate interventions, and having a framework, a set of criteria to prioritize those that would need to be priority financed. Next slide, please. So it was recognized really early on that this, although it had been approached as a kind of one-off exercise, it really only provided a starting point, and we needed to develop arrangements for implementation, for then monitoring, reviewing and improving. And it was recognized this is going to be a very long journey. Even when mature, it would need to be kept up to date for all the reasons that Srobana has explained. And I must say that if the Joint Learning Network resource Srobana introduced had been available to us, we would have certainly used this to guide us. Next slide, please. One of the most important things that we did at the beginning was to map the difference between what we called the governance arrangements that were going to be needed and the executive support, the kind of technical support that would be required to actually make things happen. Next slide, please. So effectively what we did is that we proposed a governance structure which had three key strands: policy, financing and delivery. And in that context, the Priority Benefit Package programme would be overseen by an executive team, advised by a clinical advisory group that would also have a direct line through to the policy board. And the programme would itself be supported by expert teams, technical teams who could do things like needs assessments, intervention analysis, economic analysis, implementation management, and importantly, capacity development. One of the things that we also saw a need for was an arm's length monitoring and evaluation function, and this would report directly into the policy board and provide evidence of real world impact. And that we felt was going to be really important to inform proposals to remove ineffective interventions. Next slide, please. So we've developed detailed proposals for the membership of the various boards in terms of references, for each of them, recognizing they each have a slightly different core focus, but the decisions are going to need to align through that single national healthcare board at the top here of this slide. Next slide, please. In terms of actually taking this forward, we developed two roadmaps for actions. One was focused on improving what was happening now across Sudan and taking immediate first, second, third steps to improving service availability and delivery over the coming sort of 12 to 18 months. And then the second roadmap was much more strategic, focusing on the really enormous journey associated with developing the health system financing and capacity across Sudan over the next decade, and within which that priority benefits package institutionalization would sit. Next slide, please. So where are we now? Well, there's been a lot of problems. Even without COVID-19, Sudan have been facing a lot of challenges and a lot of political and government changes. And that's exacerbated the problems because of lack of access to development finance, much of which of the work that they've done has been financed by other bodies. But the reforms do continue, and the pilots are being developed in key states, and there is very, very strong commitment from the Ministry of Health and the National Health Insurance Fund, who are leading this with the support of the WHO. So last slide, please. I just wanted to talk about very briefly the key lessons that we feel have been learnt from the Sudan experience. We're still at the beginning of this journey, but I think the success in terms of having kept on track over what's now been a 3-year period is about having that systematic, strategic approach with the right stakeholders in the room so that the reform can be co-designed and a consensus can be achieved. Having that shared vision across the system leaders really is a prerequisite for success. And I would say very importantly, the vision has to go way beyond the priority benefit package. That's only one ingredient in the system as a whole. So really thinking about how to set that institutionalization within that wider context and including, all of the system dynamics that enable the system to work effectively. So that's it from me. I'm sure when we come to questions, hopefully Mohammed will be able to join. Thank you very much.
Really excellent example, I think, of both the importance up front of like setting goals and objectives, the governance structure, the leadership, thinking about implementation in advance so that it's all part of the plan, but then also understanding it as just one piece of this whole system and that it must be planned as part of a system reform. That's very nice. Thank you so much. Okay, so now over to Tessa Tan-Torres Edejer, who is the acting head of the Department of Governance and Health Financing at WHO, who has a very large wealth of experience in this area. So we're delighted to have her on here. So Tessa, over to you to hear your perspective and the challenges you faced and how you've worked with countries. That'd be great to hear.
Thank you, Pete. I'm not going to use slides, and I will try to be brief. I think the key words for me in this work on health technology assessment and benefit package design is really, as you have mentioned, Pete, it is about priority setting. It is about thinking, what are the opportunity costs if I make this choice? What happens? What is it that I'm giving up? The other thing is really thinking ahead in terms of implementation. If we do decide to recommend or actually to provide or to recommend for reimbursement or to recommend for provision of this intervention, what does that mean in terms of implementation? What does that mean for universal health coverage? So I'll start with a few key learnings that we've had in working over several countries. Many of us wish to make the benefit package design process systematized, acknowledging that it will be revised every so many years. So one of the things we usually do is do a landscape analysis. I think one of the learnings that we now have is that it is not just about the landscape analysis of the technical capacity to actually do the work of the assessment, but it is also important to do a landscape analysis to determine where are the resource allocation decisions being done, at least within the government, if we're looking at a single basket of funds. I think this is very important because I feel that this concept of opportunity cost should be governed by the same procedures, by the same criteria in making choices. We have gone to countries, and even our own WHO HQ colleagues have basically tried to make the argument, but vaccines, Tessa, they're different. They come from a pot which is already earmarked, or essential drugs list are actually there. And we've had a long history of deciding which drugs can enter the essential drug list, and these are the only drugs which the government can purchase. These are pre-existing institutions, and they are quite strong. But I think if you also believe that they all come from the same basket of funds, that it will be the same opportunity cost for them, then even if they maintain their own separate structures, we should try to make sure that at least the processes are the same. The process that they use to determine which drug goes on the essential drug list is the same process that you use to determine what intervention goes on the benefit package. It should have the same criteria. It should have the same procedures. If you are inclusive and have the general public or a consumer organization in your HTA committee, you should have that as well in the essential drugs list. Because what makes it different? The opportunity cost, it comes from the same single basket of government funds. So it is important to define, to really figure out where are the resource allocation decisions being done, because you're not just going to work on the benefit package. You will want to work to standardize the processes, make it consistent across all these areas where these resource allocation decisions are being done. So I think that was our first learning. We don't go in with HTA and benefit package and that's it. We actually look at the entire government structure, the Ministry of Health, and say, where are the resource allocation decisions being done? And that means we need to standardize the processes. The second point that we learned is, which was so obvious, is when we do benefit package or revision of benefit package or design of essential packages or core health packages or priority health packages, there is already something existing. The governments have been providing something. Other sectors have been providing health services. And what does a core package mean? Or what does an essential package mean? Or what does a benefit package mean? I think for us, what we're basically saying, also acknowledging that some countries have gone ahead and have already officialized their essential health service package or their priority package, but have at a certain point actually realized they cannot deliver it because of primarily of financial concerns or constraints. What do you do with that? Do you revise your essential health service package? Actually, we don't recommend that because then you have to, there'll be a lot already of political buy-in in that EHSP, or at least it is already policy. So what we recommend is to position your core health package, your hopefully fully funded core health package, as a smaller set within that big set, and say, we will start with this small set. Everything else can go on as it goes on with implicit rationing, but select a core set of services which you can guarantee. That's a scary word, but in a sense, make sure that the entire population can actually avail of this, that it is delivered as a quality service, that there will be no stock outs, that there will be supervision, and hopefully incentives for the providers to actually provide these interventions. So what we're saying is you can't, there is something already going on. I'm very wary about these investments, but really trying to position more this core set of services as something that is guaranteed and which will, through time, it will still grow. I think this is important, really. I remember when we were working with Thailand years ago, when they were trying to standardize the benefit package, although they had 3 financing schemes, they wanted to make sure that every member in the financing schemes had the same benefit. So that was what we wanted, a guaranteed set, which is universally available. And I think that's one of the recommendations here of this guidance document, is to make sure everything is universally provided. So we said they were at that time trying to figure out, there were 2 things which are not yet being provided at that time. HIV treatment, that was easily put in, but then the other one was renal dialysis or renal replacement therapy. And what did they do? They made sure that actually it would be made universally available. How did they do that? They actually looked at where are our peritoneal dialysis centers, where are our renal transplant centers, how many nurses do we have who are trained in these technologies, everything in terms of how do we actually get to implement this in every corner. And they had all the data. I think they take very clearly or very, very, very strongly the idea this should be universally accessible. I remember telling some of the HTA committees, I said, never let yourself be an instrument of increasing inequity. When you approve something, are you, particularly something which is technologically complex, are you in a sense increasing inequity in terms of access by socioeconomic quintile, maybe even by just simply urban-rural division? So I think it is important that when we think about this essential benefit package, that we actually think about true implementation and making sure that there is equitable distribution. That's a step further than just benefit package design, but we should really think about it in terms of the actual decisions, not just the financial resources, but also the material resources. I think the other thing that we, and this is my last point, the other thing that we noted was, although there is still lack of capacity to do the technical assessments, the economic evaluations, there is also that part, which is the procedural part, the deliberative part, which we feel has not received as much attention as the technical part, which is all the studies, economic evaluations that we do. What we would like to go forward into the future is spend a little bit more time developing the science of this deliberation, developing this, making, how do you make it systematic, this appraisal phase of the deliberation. When you put the different criteria together, how do you use the data that you have? How do you combine it? How do you involve everybody whom you've tried to, all the sectors that you've tried to represent? How do you actually try to do it? This is the part which we think there is still need to develop the methodology, to develop the visualization tools on how to get consensus, even just talking about maybe some techniques which are already being used in other areas, not specifically in health technology assessment, like nominal group techniques, Delphi methods for moving into consensus. We would want to try looking at that now and exploring it further to try to make sure that this deliberation process is not something that is driven by vocal people, and that there is true legitimacy in that everybody who is there is represented and has a voice and is making that voice count. I think we really want this process to really be systematic in approach, even as a deliberation, very fair, very transparent, and inclusive. And one specific part that we want to look at here is the empowerment of the consumer representative. I hesitate to call it the patient representative, but the consumer representative. How do you empower those versus other technical people like the providers who are there, like economists or other methodologies? How do you empower them so that they can really participate fully in the deliberation process? So we think that empowering this group will actually make the process more legitimate and hopefully the decisions more acceptable to the people. So I think those are the 3 points that we learned or are learning, and I know we will learn more. Thank you very much for this guidance from JLN, capturing the experience of those countries. Just to repeat, it was about landscape analysis, not just about technical capacity on HTA, but really looking at the entire resource allocation field. The second one is the benefit package is something that will be put on top of something that is already existing. Let us make sure that it is fully implemented, and there are ways of making sure of this. I think I want to repeat that we do not want this benefit package revisions be an instrument for increasing inequity. And finally, going forward, we would like to see a more systematized or standardized way of looking at the appraisal and the deliberation process, and having empowered consumers to participate so that we increase the legitimacy and acceptance of the recommendations. I'll stop here. Thank you very much.
Thanks, Tessa. I was just about to summarize what I thought the key takeaways were from your, but you just did that beautifully, so I won't repeat what you said. So thank you for the three main messages from your experience. It's very much appreciated. Okay, so now can I turn to Alemayehu Hailu, who's a postdoctoral fellow at the Bergen Center for Ethics and Priority Setting, who's going to provide some of his experience looking at the benefit package in Ethiopia. Over to you, Alemayehu.
Thank you so much, Pete, and yeah, thank you, JLN and CGD for inviting me to speak here. And yeah, I have some slides maybe. Next, please. So I will be talking on the Ethiopian experience on revising the Essential Health Service Package. The Ethiopian Essential Health Service Package is revised and launched in 2019, and the process took around 1.5 year, and it was very inclusive and process, and I was leading the process with WHO colleagues and also the University of Bergen and the Harvard colleagues as providing technical support. So the revision process took, we use these 8 steps in the revision process. We start from organizing a team and defining the scope of the revision, and we end up with having the final essential health service package, and we go through identifying relevant health services, setting prioritization criteria, synthesizing evidence from various sources, and we compare and select priority package, and we regroup the interventions into high priority, low priority, and medium priority based on the criteria. And we go through also several deliberative meetings, and we did cost estimation and physical space analysis. And for example, for identifying relevant interventions, as Tessa said, we start from the existing essential package, but we also review other sources, including the WHO choice database and the disease control priority database, and we also conduct intervention listing exercise involving subject matter expert on different program areas and disease categories. And we go through also evidence synthesis for cost effectiveness, equity, financial risk protection, and we use some qualitative methods and some quantitative method, including Delphi technique and expert judgment also. And the key features, can you go back one more slide? And the key features of the Ethiopian Essential Health Service Package, we have identified 1,019 interventions, and large majority are RMNSH interventions, but non-communicable disease and behavioral interventions, all other groups of programs are also well represented in the program, in the essential package. And around 60% of the interventions are high priority interventions, while 20% are medium priority interventions, and the other 20% are low priority interventions. And in terms of delivery point also, around 60% are expected to be delivered at primary health care level, like health post, health center, and also primary hospitals, while the other 20% are expected to be delivered at secondary level, and another 20% at tertiary level hospitals. And in terms of in the essential package, we also try to group the interventions in terms of the payment mechanisms, and around half of them are expected to be delivered free of charge, including mostly at health post and primary care, and also population level interventions, including behavioral change communication interventions, and also policy level interventions, including taxation or legal enforcement interventions, and so on. Next, please. So we did also cost and physical space analysis. We start with estimating the cost of essential health service package using the price information for the input, and also human resource and infrastructure information, and also health financing, and using service coverage targets, and disease burden, and demographic information. Then we project the available resources using the national health account data, and also with policy dialogue, and also internal dialogue with the Ministry of Finance colleagues on the expected economic growth, and also debt information, and expected economic shock and recession. And also this projection was done in the beginning of the COVID pandemic. So we also take into account to some extent even if we have limited information, we also try to take into account that. And finally, we also engage with policy dialogue with the Ministry of Finance and Ministry of Health leadership on different financing platforms and innovative mechanisms to expand the physical space. Next, please. So we have come up with the cost information, and with a medium case scenario, at least around $90 is needed to deliver the essential health service package by 2030. Next, please. Then we compare the expected available resource against the cost estimate, and we identify that there is some gap between the resource need to deliver the essential health service package against the expected available resource. It ranges from 33% in 2030. Next, please. So it has been almost 2-3 years since the essential health service package was launched, and in terms of implementations of the essential health service package, I see it in two ways. One is in terms of essential health service package being translated into other guiding documents, plans, and strategies, and the other is in terms of being implemented directly, intervention by interventions. And as outlined in the chapters in the essential health service package document, the essential health service package needs to be translated into transformation plan, into human resource for health plan, clinical guidelines, and essential medicine list, and revisions of the infrastructure expansion plan also. Next, please. Therefore, the Essential Service Package launched in November 2019 came at the right time to be used into the health sector transformation plan, which will be implemented for 5 years. So I can say most of the high priority interventions and medium priority interventions are directly included into health sector transformation plan into a clear annual target and 5-year target, and it's translated into the health sector transformation plan. Next, please. In addition to that, also the essential health service package also used to inform and also to guide the 10-year development plan and also other health sector plans, including the specialty roadmap and subspecialty roadmap, especially those interventions which are expected to be delivered at secondary and tertiary levels were used in preparing national specialty and subspecialty service list, and also those which are expected to be delivered at the primary health care specialists, those at health post and health center, were also translated into health extension roadmap. Next, please. But also it's applied in other documents also. So what's next in terms of advancing implementation and regular revisions of essential health service package is I can comment on these 3 points in terms of being translated into more practical community-based health insurance benefit package, and also institutionalizations of HTA mechanisms in Ethiopia, so that the regular revisions of the interventions, as it's a dynamic process, can support the regular revisions and implementation. In addition to that, also continuous capacity building in terms of health economics, health financing, and priority setting can also strengthen this. Next, please. So we have learned, we identify around 10 lessons, but I will only focus on the last 2 parts, which are the last 3, which are linking with service delivery and financing mechanism, as Tessa outlined. The essential service package, if not linked with service delivery and financing mechanism, it will not be translated into actionable items, and linking with monitoring and evaluation is also very important to ensure accountability, and also to make sure the services are provided with the expected level of quality. Next, please. So we have documented also the process and also the evidence synthesis and other related evidence in the priority setting and essential service package revision in different articles. I would like to share this with you, and I have one more final slide. And I would like to acknowledge the leadership from the Minister Tessa for leading both revision process and also currently the implementation process, and also my colleague Getachew, who is also leading the revision process, and also support from the WHO Ethiopia and AFRO and headquarter, also Department of Health Financing and Governance, and also Ole Noraim for BSEP's team for supporting and also giving guidance in the revision process on priority setting, and also other members of the technical working group who are involved and invest their time on the revision process. And thank you so much. And
thank you, Alemayehu. That's excellent. A nice example from Ethiopia there, setting out the criteria early on for your selection of interventions, and really in-depth look at the fiscal space and Ministry of Finance dialogue, which I think is unusual and is part of your success there. So thank you so much for taking the time to share that with us. So now can I turn over to Owen Smith, please, from Senior Economist from the World Bank, to give your insights on this topic. Thanks.
Thank you, Pete, and many thanks to CGD and JLN for inviting me to join this. And just to say off the top, I think this new JLN resource guide is really going to be a terrific document for countries to use going forward. So let me just try to be brief and say that about 10 years ago, I was part of a larger effort at the World Bank to look at pro-poor universal health coverage reforms across 24 countries from all regions around the world. And one of the 5 main focus areas that we looked at was the process of benefit package definition in these typically relatively new UHC reform initiatives. And what we found was that nearly all of these countries had explicitly defined their benefit packages. And I think that in itself was a major step forward, because they were coming from systems where benefits were not defined, where everything was implicit, and that was an important achievement. But the manner in which they came up with these new benefit packages was typically fairly informal. Yes, there were consultations with medical professionals and specialties. Yes, there were consultations often with various patient stakeholders, with parliamentarians perhaps, but this was all relatively ad hoc and not very, shall we say, formalized or institutionalized. I want to talk a little bit specifically on this sort of fiscal and budget aspects. So we asked countries whether affordability was one of their main criteria in developing their benefit packages. And the answer typically was yes. But when we probed further to see whether there were specific financial constraints that were identified, sort of budget ceilings, whether they had robust exercises that informed the sort of affordability criteria, the answer was typically no. And so there was a large shortcoming in that sense. Specifically, we asked countries whether they were doing health technology assessment. Remember, this was about 10 years ago, but only 1 out of the 24 countries that we looked at was doing HTA, and that was Thailand. There were some exceptions. The Auge reforms in Chile, the fiscal considerations, I think, figured more prominently. As I recall, I think also in the Philippines, the fiscal calculation was taken a bit more seriously. But the general pattern across the 24 countries was that the fiscal and budget constraints were not really robustly taken into the process. Now, this gap, I think, one might think that the shortcoming would be sort of around the margins, that 10 or 20% gap here or there isn't a big deal. But one example, although it wasn't one of the cases we looked at, but a country that I was working in the intervening years, is Bangladesh, where they worked on an essential services package, and the per capita costed amount, I think, was something like 2.5 to 3 times larger than the budget that was available. So you have a 250-300% gap between the promise and what can be funded. Clearly, there's a major issue there. So the implications of this, of course, were that you had a lot of implicit rationing. So there were shortages of providers who could provide services both on a national level, but geographically speaking as well. Large areas a country where there was no provider that could deliver certain services within any reasonable sort of distance. You had overcrowding at facilities, informal payments, out-of-pocket payments. Most of the implicit rationing, the way it sort of unfolded, would have larger implications for the poor than for sort of those a little bit further up the income ladder. So this was sort of the environment that we were looking at. I don't want to sort of diminish the reforms because, as I said, it was really a major achievement to move from an entirely undefined benefit package to something that was explicitly defined. But just a reminder that reform happens a little bit slowly sometimes, and so in a sense, they're moving from implicitly defined to explicitly defined, but implicitly rationed. So there's still another transition to happen from implicit to explicit, and that's from implicit rationing to explicit rationing through proper exercises and institutionalization. So I know we're getting short on time. I think just a few brief additional comments. This exercise was undertaken many years ago. I do think there's been quite a bit of progress since then, and some of the work that JLN and CGD have done are very important in feeding into that progress. I think as Tessa was referring to, countries, when they introduce new benefit packages, they don't sort of land on a blank slate. They're coming on top of an existing system. And when we looked at the costs of the new benefit packages, they often looked rather small, precisely because they were sort of leveraging an existing system. They were top-up payments often, or covering things that were where there were clear gaps. And I think that creates an opportunity to try to institutionalize as early as possible in the process, because it's easier to set the rules of the game when the costs are somewhat lower. And as we know, the costs defy gravity and will always go up. And so if this institutionalization can be done when the programs have relatively small price tags, then I think the rewards will come further down the line. The second point, and I think this is just to highlight one of the important points I think made in the guidance note, is that benefit package revisions, they don't have to be wholesale. You don't have to put everything on the table all at once. And I think the sense that everything needs to be discussed in a revision can lead to delays and these sort of 27-year gaps between revisions that we saw in one country. It is possible to look at a subset, and there's a nice example of Vietnam picking off a certain number of specific services and finding that there was some low-hanging fruit. I've seen also in India that there were debates about the adequacy of prices, and prices could be revised just by looking at the top 20 or 30 most contended or debated price points, and not putting absolutely everything on the table. And I think countries need to come with this concept that it's a living document that can be revised quite regularly, and it doesn't have to be a huge heavy lift once a decade, because that's not going to be as productive an approach. The last point, I think, just to highlight, I mean, I've spoken a lot about the affordability aspect, but there's obviously a very important human resource constraint, which may be more binding than the financial constraint in specific circumstances, particularly when countries are looking at financial protection and trying to cover some more specialized secondary or tertiary health services. The providers may just not exist to deliver services on any sort of adequate scale, and so we need to look at the HR constraint just as much. I could say a little bit more on subnational fiscal issues, but maybe I'll leave that for now and we can come back to it. So thanks very much, and back to you, Pete.
Thanks, Owen. Lots of really insightful comments there. Just to first flag, we are going to go 10 minutes late, if that's okay to everyone, because I think it would be nice to have a round of questions if we can. But yeah, thanks, Owen. I particularly appreciate the Bangladesh example, three times the per capita of the budget. we often call this sort of aspirational health benefit packages. They're something that the country wants to work towards, but in reality, you get all that implicit rationing, all that problems of people queuing up, services not available, inequities that actually come when those aspirational packages interact with reality, and limited funding has to be spread over just a few services in the end. I'd like to actually, if we can, take that as a motivation for a round of questions. Can I start, Alemayehu? You seem to have a lot of success in working with the Ministry of Finance and developing the fiscal space. Do you have any advice for other countries on what that might be, on how they might do that?
Yeah, thank you, Pete. I think that's important step. I mean, the benefit package needs to be aligned with the expected available resource, and the budget is predominantly in the hands of the people or leadership at the Ministry of Finance, and closely working with them, starting from setting the scope is very important. And I can in Ethiopia the dialogue with the Ministry of Finance in the middle of the process, and could have been even much better if we start the dialogue with the Ministry of Finance early on, so that we can be more less ambitious in terms of generating the essential health service package. That's what I want to say. Early engagement is very important with the Ministry of Finance, and also knowing the expected available resource early is very important, rather than doing the physical space analysis at the end of the process. Thank you so much.
Yes, nice. Thanks, Alemayehu. And Jacque, any insights from Sudan or your other experience?
Yes, I think it was very interesting listening to the others as well, and we had a fairly similar journey to Alemayehu in terms of the sort of breadth and depth of the process, and we too, like you suggested, ended up with a health benefits package that was somewhat aspirational. But actually, I think having gone through the process of doing that, it really helped inform the priorities, because seeing what it would take to do everything that they want to do, and thinking about how long it might take them to get there in terms of not just the financing, but the capability development, the staffing, the physical infrastructure, the digital infrastructure, really gave them a kind of foundation for a long-term strategy, which is why we ended up with those two roadmaps. The short-term one, which is let's make a difference now, and then the long-term one, which is a real recognition that to get to where they really want to get, it's going to take a decade of investment and planning and capacity building. So yeah, and I would also concur about engaging with finance early. That was one of our challenges, is getting the Ministry of Finance engaged at an early stage, and I think that's resolving itself now.
Great, thanks, Jacque. Tessa, over to you. When you're working with countries advising, you talked also about this idea of focusing on a core package and allowing the central package perhaps to stay there. I don't know if you've got any other insights on how you try and help countries to focus on the limited fiscal space and the reality.
If it's a new country we're going into, I think one of the first questions we ask is where is your health financing strategy? And do you have a recent fiscal space analysis? But that's not enough, not at all. It just gives you the context of, just to give you an entry point of understanding the situation. But I mean, we have a practical experience of a country where we were asked to go into there, but then they say, no, Tessa, you cannot touch our essential health service package. It is in the Constitution. You cannot touch it. So we said, okay. So it was exactly what Jacque said. We said, let's cost it. Let's cost it and show them how much, because we read their health financing strategy. We knew how much they were spending per capita. And we said, okay, let's try it this way. And then even if we can't touch it, we can work with by putting incentives in terms of which are the performance based indicators. That is how if we cannot touch it and form or say this is the guaranteed package, we will then do it through the other side on the monitoring and evaluation, and start helping put performance based incentives for these specific interventions in the core package in the hope that it can work. So I think it's always for us, you need to work in those specific contexts, but at the same time, you need to keep your eye on the ball, which is basically, you really want a universal package. And therefore, an aspirational benefit package will not achieve anything in terms of actual implementation and particularly accountability. So I think this is important. It's just an example of saying you don't really need to work in the list of services. You can start working in terms of the other side if you can touch it. Ideally, you should do both.
Yes, exactly. Rob, thanks for coming and turning your video on. You're welcome to answer this question. One other thing I was thinking of putting to you, because I really liked one of the sections in this guide that you wrote about, like using the right method for the right question. And one of the ideas that Owen just raised was you can do partial health benefit package revisions, right? So you don't have to do everything. And you've had some experience of this, I think. So I wonder if you could discuss some of the sort of pros and cons of that. Like, what are the benefits of just taking a little bit and revising that alone?
Yes, thanks, Pete. It's indeed finding the right approach for the specific challenge a country is facing. And like Owen just said, it can be a heavy lift for a country to do a full package review. I'm sure it's a heavy lift for a country because it can take 2 years' work and involving maybe 10 full-time analysts looking at Alemayehu and Jacque who have gone through this. At the same time, alternatively, you could, depending on the context and the political dimension, you could also opt for a more long-term strategy, like we're now doing in Iran, where we cover a condition per condition. So we worked on multiple sclerosis, then diabetes mellitus. Now we're covering neurological disorder. We're doing the same approach in Rwanda. The advantage is that you build capacity alongside the way, and you are closely involved, at least as a technical consultant, in the first disease areas, and gradually you remove yourself from you take more distance from the process. Plus, you can actually pay more attention to details. If you do a full-blown review, unless you do it for 2 years, like Alemayehu and Jacque did, that massive investment. But if you need to do it faster, you can only have like maybe in the appraisal meeting 10 or 15 minutes per service, and it comes down to that much time, which doesn't do good, I think, for the whole process. So maybe it's like Owen says, you could do condition per condition and see it as a gradual thing and like a continuous thing, an institutionalized process.
That's right.
And maybe that's better to sustain rather than every 5 or 10 years this big bang. And so these are my thoughts.
Thanks, Rob. Gosh, we could go on for another half an hour, it feels, but I think unfortunately we're at time, so I'm going to have to wrap up. So thank you to all the panelists. Thank you to the JLN member countries for contributing their thoughts to the knowledge product as well. I think we've heard some really important insights here today about the need to make health benefit package a core part of a kind of the system, a core policy, not just a kind of technical exercise, but a political exercise that starts with defining goals and objectives, that thinks through the budget available and the kind of how this forms a core part of the system. We've heard from Sudan and Ethiopia some particular examples. We've heard about Tessa's thinking through the kind of 3 core messages from her experience about making sure that you're guiding resource allocation decisions and the right health financing systems, about the tension between what's optimal but also what's actually feasible given the reality on the ground, and some really interesting conversations about procedure and making sure that the right people are empowered and consulted as part of that. I think we've heard a very clear message about the concerns with ambitious and aspirational packages, and the importance of fiscal space analysis, but going beyond that into detailed Ministry of Finance dialogue. And then finally about kind of options that were raised just at the end about you don't have to do all of it all at once. It can be an ongoing living document that's revised over time to be closely aligned to the changes in your country's budget and kind of health service reality. So thank you to everyone for your contributions. I think this is just the start of obviously of an ongoing conversation about health benefit packages. Thank you to everyone.
Thank you.
Thank you. Thank you, Pete.